Hello dear viewers, today in this video, which is part 3 on nutrition support in critically ill adults, I will discuss the enteral nutrition in critically ill patients. Nutrition support is part of comprehensive management of critically ill patients because it impacts the outcome. I am Dr. Sunil Garg from Essentials of Acute Care. Enteral nutrition support refers to the provision of calories, protein, electrolytes, vitamins, minerals, trace elements, and fluids via an intestinal route. Here it is important to note that it is related to intestinal delivery of nutrition support and not to be confused with only orogastric or nasogastric tube delivery of nutrition only. It means the route of delivery may vary, but as long as nutritional delivery is taking place in intestine, it is considered as enteral nutrition. Enteral nutrition is the most common mode of delivery for nutrition support in intubated critically ill patient, and to initiate enteral nutrition, appropriate access must be obtained and the prescription needs to be determined. Contraindication to enteral nutrition support includes patients who are not hemodynamically stable and or in shock state, particularly before, during or in the initial hours of post-resuscitation, as there are risks of bowel ischemia. Other conditions where enteral nutrition should be avoided include bowel obstruction, severe and protracted ileus, major upper GI bleed. Remember, mild GI bleed is not a contraindication for enteral nutrition. Patient with intractable vomiting should be avoided enteral nutrition until vomiting settles. And patient who has evidence of bowel ischemia, high output GI fistula, and abdominal compartment syndrome should also not be offered enteral nutrition. In critically ill patients, enteral nutrition is most commonly delivered into the stomach. However, in select patients, it can also be administered into the more distal part of alimentary tract. For example, post-pyloric feeding. Feeding through an enteral tube should not begin until its proper position has been confirmed radiologically. Gastric feeding is typically delivered via an oro or nasogastric tube. Oro or nasogastric tube are available in two varieties, sump or feeding tube. Long-term feeding can be done via other routes, and these include percutaneous endoscopic gastrostomy tube, percutaneous radiologic gastrostomy tube, and surgical gastrostomy or jejunostomy tube. Regarding post-pyloric feed, most patients in the intensive care unit do not need post-pyloric feeding, means when feeding tube tip is in the duodenum. Placement of post-pyloric feeding tube is challenging in critically ill patients since they often require endoscopic or radiologic guidance, and indication include patients with delayed gastric emptying or gastric outlet obstruction or failed aspiration precautions. Several enteral nutrition formulations are available for patients with critical illness. Common difference between formulations include the difference of osmolarity, caloric density means how much calorie is provided in 1 ml, amount of protein per calorie, and electrolyte content. Most are formulated to provide 100% of the recommended daily vitamin and mineral dose when a minimum of approximately 1000 kilocalorie or more are delivered per day. In addition, there may be differences related to whether they are intact or pre-digested, fiber or disease-specific nutrients are present or absent. No formulation has consistently demonstrated superiority over others. Choosing among formulations depends upon clinical factors including volume status and comorbidities like kidney failure. For most critically ill patients, standard enteral formulation provides sufficient nourishment if given with adequate total daily volume. For patients who require volume restriction, the use of concentrated EN formulation means 1.5 to 2 times more concentrated than standard formulations. However, when volume is adequately controlled using other means, like by diuresis or dialysis, standard feedings are acceptable. The routine use of concentrated EN or enteral nutrition does not appear to confer benefit when compared with the standard formulation. For patients with kidney failure, renal formula is appropriate. The exception is patients on continuous kidney replacement therapy, since continuous kidney replacement therapy is highly effective at removing electrolyte such as potassium and phosphate. Renal formulas are also typically more concentrated than standard formula, which can be useful if the patient requires both fluid restriction and electrolyte control. Pre-digested formula, previously called semi-elemental or elemental formula, contain peptide as opposed to intact protein. Carbohydrates are in less complex form and the total amount of the fat may be decreased with an increased proportion of the medium chain triglyceride or the triglyceride structured to contain various mixes of fatty acids. Patient with chylous accumulation, for example, patient with the thoracic duct leak, chylothorax or chylous ascites, or digestive defects like short gut or malabsorptive syndrome that are unresponsive to supplementation with the pancreatic enzyme, or intolerance of standard enteral nutrition like patient with the persistent diarrhea may be prescribed pre-digested formulations. The selected pre-digested formulation depends upon the suspected underlying problem. In critically ill patients, studies of the pre-digested food products have not demonstrated difference in mortality, infectious complication, or the incidence of diarrhea when compared with the standard enteral nutrition. The use of diabetic or other disease-specific formula like hepatic formula and pulmonary formula have not demonstrated superiority to standard feeding products in patients who are critically ill, hence it should not be used. There is no role for other supplements like glutamine since these have not demonstrated any clear benefit. So what is standard formulation? Standard feeds are the most common enteral nutrition formulation used in the intensive care unit. The following characteristics are typical of standard enteral nutrition formulation. Standard formulations are isotonic to serum, caloric density of approximately 1 kilocalorie per ml. They are lactose free. They contain intact non-hydrolyzed protein, content of about 40 gram per 1000 ml or 40 gram per 1000 kilocalorie. Non-protein calorie to nitrogen ratio of approximately 130 raised to 1. Mixture of simple and complex carbohydrate, long chain fatty acids, although some are now including medium chain and omega-3 fatty acids, and they contain essential vitamins, minerals and micronutrients in daily recommended allowances. The daily volume of feed is first based upon estimated caloric need, means carbohydrate and fat content. Then the appropriate formula that best delivers the estimated protein needs is chosen. If protein needs cannot be acceptably met with the available feeding product, protein supplements may be administered. Standard enteral nutrition delivers around 50% of the calories as carbohydrates and 30% of the calories as fat. The nutrients and supplements which are of unproven benefit includes omega-3 fatty acids, glutamine and its precursors like arginine, HMB, combined immunomodulator supplements, prebiotics, probiotics, extra fiber, antioxidants, vitamins including vitamin D and trace elements provided in excess of the daily recommended requirement have been studied in critically ill patients. The available evidence has not demonstrated a clear benefit of these supplements, therefore not suggested for routine administration as daily allowances is met with the standard formulation. Fiber supplementation is an option for patients with the enteral nutrition related diarrhea. Levels of vitamin D drops in critical illness Despite a correlation between low vitamin D level and intensive care unit mortality, studies show that vitamin D supplementation has no clinical impact even in patients with low level. The daily amount of enteral nutrition is tailored to the nutritional and fluid need of the patient. Enteral nutrition is typically administered as a continuous infusion over a 24-hour period. Calculating the goal target rate involves calculating the dosing weight as well as the caloric and the protein target goal. The volume and rate are calculated based upon the caloric need of the patient and the caloric concentration of the formulation used. For most patients, enteral nutrition is initiated at an hourly rate that is less than the full desired target, means 30 to 50% of the ultimate target goal, then slowly increase the rate over 3 to 7 days until the full target is reached. Most patients require supplementation of water, for example, like 100 ml every 6 to 8 hours in addition to EN formulation, and all feeding tubes should have periodic water flushes to minimize clogging. Now we will understand how to calculate it. Suppose our patient weight is 60 kg and assuming caloric and the protein needs 25 kilocalorie per kg and protein need 1.5 gram per kg per day. So target caloric intake is 60 multiplied by 25 and it will be 1500 kilocalorie per day, and target protein intake 60 multiplied by 1.5 and it will be 90 gram protein per day. The best match for this patient would be a high protein formula with a caloric density of 1 kilocalorie per ml and a protein concentration of 60 gram per liter. The total volume required to meet caloric need will be 1500 per ml per day, since 1 kilocalorie is there in the 1 ml, and the total protein from this volume of 1500 ml will be 90 gram of protein per day, as 1 liter contains 60 gram per liter. The target rate for the full continuous feed 1500 ml will be divided by 24 hours, so it will be 62.5 ml per hour. Rounding up to 65 ml per hour is reasonable, and appropriate starting dose, as I mentioned, it will be 30 to 50% of the target volume. So 65 ml is the target volume and 30 to 50% of 65 ml will be approximately 20 to 30 ml per hour to begin with. Monitor patient for complication associated with enteral nutrition, and it includes feeding intolerance, aspiration, gut dysfunction like diarrhea and constipation, fluid and electrolyte imbalance, and refeeding syndrome. Routine measurement of gastric residual volume as a way to assess tolerance of feeding to prevent aspiration is not required. Measure gastric residual volume only in patients exhibiting signs of intolerance, and if gastric residual volume is more than 500 ml, hold feeding. The cause for the elevated gastric residual volume should be investigated and should be addressed prior to attempting to feed again. The most common cause of increased GRV or gastric residual volume includes ileus and delayed gastric emptying. Resume feed as early as applicable. In most cases, feeding intolerance is due to ileus or constipation. Studies have confirmed that aspiration of oropharyngeal secretion is the main cause of nosocomial pneumonia in the ventilated patient and have failed to demonstrate that aspiration of gastric content is a significant cause. It is important to note that there is no contraindication to enteral nutrition when patients are ventilated in the prone position. Enteral nutrition does not need to be interrupted for diarrhea and should be continued while the etiology is being investigated. If diarrhea persists and enteral feeding is still suspected as a etiology, switch to a mixed fiber containing enteral nutrition formula. Use fiber with the caution in patients with the impaired peristalsis like patients with the who are receiving vasopressors due to the risk of precipitating a fiber withdrawal. When supplementing enteral nutrition with extra fiber, prefer highly soluble fibers where the effect is primarily osmotic, and this includes guar gum, wheat dextrin, inulin, or fructo-oligosaccharides. If diarrhea persists in patients receiving highly soluble fiber supplementation, discontinue fiber supplementation. Here I finish, and I will continue with the nutritional support in critically ill adults in my next video, and I will discuss on parenteral nutrition. If you have any feedback, suggestions or comments, please write down in the comment section. Till then, bye and take care.